間になりましたので、これも回数も書いてないんですが、忘れました。東京大学、医学教育国際研究センターの医学教育セミナーを行わせていただきたいと思います。本日は今年去年の10月からずっといらっしゃっていた客員教授のジョイス・ピカリム先生の単位の最終講義になります。先生は3月いっぱいで引退されてカナダにお戻りになりますが、その直前の今最終講義です。タイトルは医学領域のプロフェッショナリズムの教育と評価。プロフェッショナリズムというのは日本の医学教育界でももうポピュラーになった言葉です。ただ実際にどうやって教育し、さらにはどうやって評価するかということに関しては暗中模索の状態が続いております。今日の講演で、その真っ暗なところに一つの光が当たるといいなと思っております。そう、よろしくお願いします。
これから光をつけましょう。First, I want to thank a whole lot of people who helped me in discussing this presentation. So I want to thank Dr. Chris Holmes, Joe Green, Dr. Tamara, Dr. Norma Weiss, Dr. Daisuke Son, all of whom helped me and even provided me with copies of Blackjack and Akahige, so I could understand professionalism in Japan better, and also especially to Dr. Onishi, who put in all the Japanese. If there are any mistakes in the Japanese, it's his fault. So this is my outline for the talk today, to define medical professionalism, to see whether or not we can predict professional behavior, whether we can measure it, and whether we can teach professional behavior. So more specifically, my objectives are to be able to describe the various components of the current definition of medical professionalism, to be able to describe the existing studies about predicting professional behavior, and then I want to show you really an example of one way in which we teach professionalism, and hope that that might give you some ideas. So, in terms of the definitions of medical professionalism, there is the official definition, which most people use, which was put together by the American Board of Internal Medicine and the European Federation of Internal Medicine. But I also asked a few other people what they thought being professional meant. When I asked the medical students at Tokyo University, they really focused on the skill and the knowledge. If you're very good at what you do, if you're an excellent surgeon, for example, that was what professional meant to them. It's interesting because most medical educators, when they talk about professionalism, mean the other aspects apart from your skill and your knowledge. But most medical students think it's just about being good at something. I also asked a few nurses what they understood by professionalism, and they felt that being respectful was the most important thing. Respectful towards patients, also respectful towards other health professionals. Oops. And then there's also sort of a historical definition of professionalism, which isn't always so positive. It really has to do with a kind of monopoly based on specialized knowledge and a belief that's being used for societal benefit. And Many of you may know that in professional societies fight very hard to make sure that other people don't do the things that they're good at. They don't want anybody else to come into their territory, if you like. I'm going to go back to the official American Board of Internal Medicine Foundation definition. There's 3 fundamental principles: patient welfare, patient autonomy, and the principle of social justice. And then there's 10 professional responsibilities that are listed as well. And these are the 10 professional responsibilities: competence, honesty, confidentiality, appropriate relations, improving quality of care, access to care, just distribution of resources, scientific knowledge, conflicts of interest, and commitment to professional responsibilities. These are all, in English, we sometimes call them motherhood statements, which means that nobody can really be against any of these things. These are all obvious things. And the question is really not whether you agree with these or not. Almost everybody agrees with these. The question is really, how does it translate into real life decisions? Here's another definition that is commonly used, and I will say that, again, it's a bit of a motherhood statement. It's hard to disagree with this. It's demonstrated through a foundation of clinical competence. So the clinical competence here, you see, is what the medical students thought was most important, and even in here, in this definition, it's the foundation, but also communication skills, ethical, legal understanding, and then you aspire to wise applications of the principles of professionalism, excellence, humanism, accountability, and altruism. And some of you may be familiar with some of the thinking. Dr. From Kyoto has been just published this recently in Academic Medicine, Dr. Nishigori, on Bushido as a background for perhaps Japanese principles of professionalism. Some schools use the term physicianship, and I like the term physicianship because it's a little bit more explicit about the different components that go into how we think a physician should behave. So, for example, some of the components are really have to do with skills and self-regulation. They're the professional aspects of a doctor's job. And some of them are really more related to morality and caring, like compassion and altruism. So at my university, McGill, and also at UCSF, and probably a number of other schools as well, they use the term physicianship. For the rest of this talk, though, I will use the word professionalism because that's what most people use. But it can be helpful to think about it this way. For example, just to draw your attention to the 2 components, the cruises drew this diagram. So here are the healer. If you're a healer, these are the things you need to be able to do: to care, to be open, to respect the patient, to have presence, and so on. You also need integrity, honesty. If you're a professional, you need to have autonomy, self-regulation, responsibility to society, and then you have overlapping areas which are competence, commitment, and confidentiality. So this can be an interesting way to think about some of the attributes. I also think it's important to think of 2 other aspects of professionalism. The first is that it's generally not helpful to say someone's unprofessional and someone's very professional. We all, at times, do things that are probably unprofessional. So it's probably better to say that we all have lapses in professionalism rather than to label someone as professional or not professional. The other thing that I find very helpful is to think of professionalism often not always, but often involving a choice between two things that are both good. So here is a very common problem. You have an older doctor in your department. Maybe he was your teacher. Maybe he was the department chair. Now he's getting older, he's less competent. You know, maybe even he's starting to do some things that are dangerous. What should you do? Well, here we have two things that we have to think about. The first is that it's very good to be respectful of our teachers, to have collegiality towards other people, but it's also important to regulate our profession. So which of those two things is more important in this situation? They're both good things. I don't want you right now to answer that question, but I think there are many times when being professional is about saying, this is good too. Which is the right thing among those two good things to do in this particular case? So I'm going to leave the definition of professionalism there because I think that most of us will agree on most of the time what is professional behavior. And I want to talk about predicting professional behavior. So for this, I'm going to take you through two studies done by Dr. Papadakis, who was the Associate Dean, maybe she still is the Associate Dean, at UCSF. And what she did was she published two studies looking at the association between unprofessional behavior during medical school and subsequent state medical board disciplinary actions. So she used a case-controlled design, and her cases were all the physicians who had disciplinary rulings by the state medical boards. And the controls were classmates from the same year and same specialty. So in the first study, she looked at the UCSF graduates and the State Board of California, and the second study was really the same kind of study, but she expanded it to 3 other schools and 40 different state medical boards. And you can see where those articles were published. So what were the cases? So the cases were physicians who were disciplined. In other words, they were found guilty and there was some kind of penalty between 1990 and 2000. And these were the things that they did. They were negligent, or self-use of drugs or alcohol, unprofessional conduct, inappropriate prescribing, sexual misconduct, conviction of a crime or fraud or unlicensed activity. Now, I put in mental illness down here in brackets because mental illness was a reason for sometimes taking a license away from a physician, but it's not really a professionalism problem, it's a medical problem. And so I've put that in brackets at the bottom here. But this just tells you that when there's a problem with a physician, 96% of the time it was a professionalism problem. So that's the big issue for the state medical boards. It's not so much incompetence. So you very seldom lose your license for just plain incompetence, at least in California and most of the other United States. Then, once they had their cases and their controls, they searched the medical school records and they looked at the following things. Your undergraduate grade point average. So this would be your marks before you came to medical school. So this is before admission. Also your MCAT score. Again, this would be before admission. Then they looked at your marks in medical school, and they looked at the national board results. And they also looked at were there negative comments in your school record at any time during your medical school time. So this could be from your clerkship mark, it could be from reference letters, it could be from interview reports or any other document. So searching the record. And then they classified the negative comments by category. So in the UCSF, the first study, they had 68 cases and 196 controls. So there was no significant association, in other words, no impact of these things on having disciplinary action by the state medical board. Your sex, MCAT score, failing at least one medical school course, or undergrad GPA. There was a significant association if there was a professionalism problem present in the school record. So it seemed to predict later state board disciplinary action. The odds ratio was 2.15, and it was statistically significant. Now, there's many different kinds of unprofessional behavior. So what kind of problems? They analyzed them. So there were 3 in the first study that showed up. The first was poor reliability and responsibility. So these were students who maybe were late for clinic many times, or didn't hand in their reports, or didn't complete the dossiers of the patient. So that was poor reliability and responsibility. The second was lack of self-improvement adaptability. So if someone said to the student, you know, you're a bit weak here, why don't you do this? Instead of the student saying, okay, they would like argue back and say, no, I don't really need to change. Poor initiative and motivation was another one. Interestingly, the things in this study that were not important were being immature, having poor relationships with either student, staff, and faculty, or patients' families, not upholding the school honor code. So that usually means cheating. So they copied something, or they cheated on an exam. If the person is a show-off or needs to be the center of attention, or anxious or insecure, in this study they were not significant predictors. Now, they did the same study with 3 schools, so they had more cases and more controls. So they found the same thing. Unprofessional behavior in medical school was a strong predictor of subsequent state disciplinary action. Now, in the second study, they also showed that the students who were weak academically also, as measured by a low MCAT score, low undergrad science GPA, these are before admission, remember, low USMLE step 1 after admission, low marks in year 1 and 2 were also associated, although the association was weaker. So it did seem that the academically weak students also were more likely to have disciplinary actions later on. And then again, when they went back and said what kind of unprofessional behavior, the top 2 came out again: irresponsibility and diminished capacity for self-improvement. And this association was quite strong when there were 3 or more comments in the student's record. So if on 3 different occasions the student was noted to be late or did something that was irresponsible, it was quite strong, but it wasn't statistically significant if they only had 1 or 2 comments. The negative professionalism comments were present in about 40% of the disciplined physician-student records and in 20% of the control physician-student records. So that tells you that 60% of the disciplined physicians had nothing in their school record, and lots of the students with some comments never had a problem, at least that was disciplined by the state medical board. So it is significant, but it's not very sensitive, and it's not very specific either. Now I'm going to talk about measuring professional behavior, and I'm going to show you one way we try to measure professional behavior at McGill. So we developed something called the PMEX, the Professionalism Mini Examination. Some of you are probably familiar with the Mini CEX, the Mini Clinical Exam. The Mini CEX is when you watch a student or a resident do examine a patient, maybe only for 10 or 15 minutes, and grade them on that actual encounter. So the idea was, can we do the same thing with professionalism? So they developed a small sheet of paper with 25 items on it to be filled in by the staff physician, and the categories that it included were the doctor-patient relationship skills, reflective skills, time management, and interprofessional relationship scores. It had good content validity, and it's actually been tested in Japan. St. Luke's Hospital has done this and published on it. So it's been shown to have good content validity in Japan as well. The reliability is 8 to 10 required per student, and there is unfortunately no predictive validity data available. It doesn't mean there isn't predictive validity, just we don't have any data. But the big problem with this, of course, is the 8 to 10 required per student. You know, we have trouble getting one evaluation sent in at the end of each clerkship. We couldn't imagine trying to get 8 papers on every single student to come in to analyze them. So that was the big problem with the PMEX. It just didn't seem practical. We had another problem with it, which is that we didn't like the idea of saying that professionalism is one thing and your clinical ability is a separate thing. We really think they should go together. And so having separate forms for professionalism and clinical ability didn't seem quite right. So we don't use the PMEX forms the way they were originally developed because of these 2 reasons. It's not practical to have faculty fill in this form 8 different times for each student. Okay? So we have 180 students in each class, so 8 times 180, it's a lot of paper. But the other issue is we didn't want to separate these attributes out. However, it was still very useful to us, the development of these forms, because we used the principle and we incorporated them into our clerkship evaluation form that we use now for all our students. And I'm going to show you the form. So first I have to explain that our clerkships are mostly 8 weeks long, and at the end of 8 weeks, one form gets filled in and sent to the Associate Dean's office. So that means that in our 3rd year, which is like year 5 here, we get 6 forms on each student, right? So 8 weeks times 6, so 48 weeks. So we get 6 different forms. And the form has a top part and a bottom part to it. And just for space, I'm going to show you the top part and the bottom part on separate slides. So this is the top part. So we call this our physicianship behaviors part. And here are the things we want measured. Did they listen to the patient? Did they show respect for the patient? Did the student function well as a member of a team? Did the student accept feedback? Maintain an appropriate appearance? Show awareness of limitations? Demonstrate honesty and integrity? Completed tasks reliably and was on time? And then any comments. And what we ask them, the faculty member, to do is to either check not observed or not consistently, means sometimes they didn't do this, or consistently. So the student always did these things. So that's the top part of the form, and I'm just going to draw your attention to this one, completed tasks reliably and was on time, because that is the problem that showed up in the Papadakis studies as being the most predictive. Accepted feedback was the second most important aspect. So those 2 are probably the most important. Then the bottom half of the form looks like this. So we want to know about their knowledge, their data collection, their physical exam, differential diagnosis, clinical judgment, technical skills, case presentations, written skills, responsibility in performing clinical duties. It's sort of interesting because we have that in both the top part and the bottom part. but the clinicians wanted to keep it that way in both parts, and so on, then comments. And then we grade them here on 5 different categories: not applicable, unsatisfactory, below expectations, meets expectations, exceeds expectations, or superior. Now, what do we do with the physicianship behaviors? So, just to show you, whoops. So you see here, again, we're looking for a not consistently. So for example, a student during surgery rotation, they might get a not consistently for completing tasks reliably and was on time. That would be one not consistently. Then maybe they do a pediatrics rotation and they might get another one there. And they might get obstetrics and gynecology, maybe their problem is a different category. Maybe they didn't listen to the patient. So that's what we're looking for. Now, if we have only one not consistently, so let me give you an example of a medical student. He has one not consistently on his record. Usually we don't do anything. Now, it depends. Obviously, if it was a very bad thing, like he hit the patient, of course we will do something right away about that one. But let's say the patient was late one time for clinic. We don't do anything with just one time. It's the only time. Let's say it happened 2 times. So once in medicine, once in pediatrics. All the others were okay. Then what we do is we call the student to come to the office, and we have the student meet with a counselor. We say, are you having personal problems? Do you need an alarm clock to wake up in the morning? Can we help you to deal with some of these problems? So in general, the goal is to help the student. And in general, again, there's no academic consequences, although it will depend a little bit on what exactly the problem was. Now, if the student gets 3, it's like 2 is a yellow card and 3 is a red card, sort of. So if there's 3, then it's a big deal because the student has to come to the promotions committee, and we put a comment in the student's record, and that goes with the student when they apply for a residency position. So it's a very negative thing for a student to have a comment in their record. Most of our problems with students are in the completed tasks reliably and on time. That's where they mostly get their not consistently over and over again. Every year we have 2 or 3 students. This is out of 180, so it's not very often, but we have 2 to 3 students who have 3 not consistently in the same category. So far, we have 1 student who academically was fine, but he had multiple not consistentlys, and he was dismissed from the faculty for that. And we have 1 student so far who repeated a year because of multiple not consistentlys in their record. And then we have a few others who it appeared on their record and that probably had a negative impact on their application to residency. Now, it's important, of course, if you evaluate students for something, you really should evaluate your faculty for the same thing. Are your faculty members doing what we ask the students to do? And based partly on the work with the students, we developed a form for faculty evaluations. So this is what the students evaluate their clinical supervisors on. So they're asked to evaluate their clinical supervisors about knowledge and skills. They're asked to evaluate their supervisor on teaching skills, on caring for patients, and on being a professional. So for example, good time management shows up here. So if the faculty member is always late, okay, we want the students to tell us that the faculty member is always late. And other things, showing empathy and compassion, actively listening and showing interest in a patient. So we want to tell both our students and our faculty that we think these things are important and we evaluate you on them. When students evaluate their clinical teachers, first of all, they do it online and it's anonymous. So the faculty member doesn't know which student or which resident filled in the form or gave them a bad mark. We compile them annually, so we put together all the evaluations and calculate the average, and we send it to the faculty member, usually just once a year. So once a year they get the average numbers. However, there is an automatic electronic notification that's sent to the associate dean for a low score on any item. So if, for example, it was a low score on respectful interactions with students, the associate dean will see it right away. You don't have to wait for the end of the year. So what do you do with that? Well, first of all, the compiled evaluations, we use them for promotions and we use them for annual performance review. And in general, you handle the low scores very much like the student ones. So for example, if only one time there's a faculty member, usually, because they would come to me as the associate dean, I would look at their other evaluations. If everything else was always very good and just one time I got a low score, I probably wouldn't do anything. But if 2 or 3 times the same faculty member had the same problem, I would usually call the department chair and say to him, you have a faculty member who's getting these kind of evaluations from students. Please contact them and discuss the problem with them. So that's usually how that's handled. So that's how right now we are measuring professional behavior in our students and in our faculty. We also measure it in our residents. It's very similar, a little bit different. I won't go into that detail right now. Now I'm going to talk about teaching professional behavior. Now, the Cruzes, who have published a lot on professionalism, and some of you may be familiar with their work, feel strongly that first you should teach the cognitive base. So you teach things like these are the elements of professionalism, but you have to follow that with situated learning. Situated learning just means you should learn on the job or you should discuss real-life scenarios. We have quite an extensive physicianship curriculum at McGill. There's lectures, there's small groups with mentors, there's white coat ceremony, ethics teaching. There's recall days during clerkship when all the students come back from the hospital to the Faculty of Medicine to discuss professional issues. We have simulation and of course the evaluations that I just showed you. I know that there's a comprehensive 6-year program beginning this year at KU. If you have further questions, you can speak to Dr. Hirakata after the lecture, just beginning. I'm going to show you an example of a simulation-based training session in ethics and dealing with difficult team members that we do for clerkship students at McGill. It's a video, and in the video they're talking English and it's not always easy to understand. So I'm going to give you a summary right now of what happens during the video. So before the student enters the room, the student reads a scenario, and the scenario says they did the physical exam on the patient, Mr. Peltier, but they did not do a rectal exam because the patient refused, saying he already had a rectal exam earlier that day. The student then comes into the room, and then just a few seconds later, a resident comes in and says to the student, "Did you do a complete physical exam, including a rectal exam?" And the student explains that she did everything, but she did not do the rectal exam because the patient said he didn't want a rectal exam. So then the resident tells the student she must do the rectal exam, and he tells the patient, this is a teaching hospital, students have to learn, and it's for your benefit. Then the student tries to negotiate with the patient. I have very small fingers, it will only be a few seconds, and then she says maybe I can come back later. But the resident insists that she has to do it, and he has to check off that it's done on the student evaluation. So the patient finally says all this arguing is making him tense, it's not good for his heart, and he agrees to have the rectal exam done. The resident says, great, so now he agrees to have it done. And the student still feels uncomfortable, finally refuses to do the exam, and the resident is angry and leaves the room saying he's going to talk to the student staff. So I just want to remind you the patient is an actor and the resident is an actor in this movie, but the student is a real student, and I have the student's permission to show it to you. So this is the patient waiting here. The student is outside reading the scenario, and in a minute she will walk in and start talking to the patient about...
Enter your room and begin scenario now.
Hi. Healthy, hi. I met her. We met earlier before.
Yeah.
How you doing?
I'm feeling a little better.
Good.
Hi. How are you?
Good. How are you?
Excellent. How are you? Fine, thanks. Good. Physical examination done?
Yes.
Excellent. Is your rectal examination done?
Mr. Peltier asked me not to do a rectal examination.
Okay. Sorry, I didn't mean to snicker. I keep hearing the same excuses today. Anyway, this is something that you have to get done because it's been a really busy day. So we're going to ask you to lie on your left-hand side so she could perform a rectal examination.
You mentioned that you've had a lot before and you've had a lot of...
Okay, the last thing I need you to do right now is to make excuses. Sir, this is a teaching hospital and would require students to learn, and this is for your benefit as well. Okay?
Well, I've already had 3 since I came in here, and really I'm here because of my heart, not the rest of my body. I'd rather not have
Can we come back and do it again and again?
No, because I can't have this happening every time, and I don't know what we can do to avoid this situation in the future. I have the staff to go to. I developed the right, and you know what? I can't waste time or time. I need to get done.
Okay.
So,
I completely understand. Maybe if you give me a little bit more time, I can
by all means.
try and talk to you.
By all means.
Mrs. Peltier. Hi. I hate to do this. It seems that I do actually have to do a rectal exam. Would be very 4 seconds. And if there's small thing that can happen, it would be very quick to do. If that's okay with you.
I'm really not comfortable
No.
with this. I'd really rather not have one.
Is it absolutely necessary for the
yes, let's just, he's refusing now, and there's a few reasons why he's refusing. A is because you didn't put it to him properly the first time, and now he sees that it's more all over you, and, you're going to have to find your own way to do it that it gets done. Now, in the on very honest case, it happens that, a patient will really, really refuse it, but every patient refuses it, but told properly, they are going to execute it, okay?
Absolutely.
Okay.
But I just, maybe you would explain to me why if you just had a heart attack. But I understand if he had blood diarrhea or something, I would do it in a second. I didn't do it because I felt like it wasn't absolutely necessary in his case. So I just...
And then I'm going to respond that there might be a reason why we have to do it. There might not be a reason. My job is to see that you've done it. That's my job. That's my boss tells me that you've done it, okay? I don't ask questions why, how, when. I come in, I have to take the sheet with the physical examination, with the rectal examination done.
On all days, like
That's my job.
even if we go to another patient after and I tell you that I've done a rectal on another patient, and
Why? It's done right now, and I don't know.
Dr. Butler, this conversation is stressing me out a whole lot, so I'm just going to agree to have the rectal because you guys are making me tense and my heart is really not.
I'm sorry, sir. Okay, so that's great. He's actually agreed to do the rectal examination. So if you can get this done, it's actually perfect. Just one glove left and get me the results, okay?
okay. Yeah. Can I talk to you outside?
No, you can't talk to me outside. Now I have to let your evaluation. Are you going to do it or not?
No.
No. Good. We go talk to your staff.
There it's over.
So now, the most important part is actually the feedback afterwards. So now, you will see two students who are watching. They'll come in with the first student, Nadia.
Thank you.
Thank you.
So this is Nadia, and then this is one student.
She's listening on another part of the surgery.
The second student. And this is the faculty member, the teacher.
I do not like having those conversations with those patients.
Okay.
I've had that conversation before, and it was still happening, but I think I would have got that resident afterwards, but that was just professional.
So I'm going to stop that there because it goes on for almost 20 minutes. But what he actually says to her, she says, I've had that experience before. And he says, so this is very realistic for you? And she says, yes. And I just wanted to also let you know that when we prepare these scenarios, we write them based on things that students write. So they write an essay at the end of third year, and we ask them to talk about experiences that were very important for them. Sometimes they're very good experiences, and sometimes they're very bad experiences. And after we read them, and if we think they would make a suitable scenario, we ask the students permission to use it, sometimes modified a little bit. But it does mean that the scenarios we're using are all based on things that have really happened. So being asked to do something by your boss when you don't think the patient really wants it. Oh, sorry. So our feedback after the scenario, our goals are that we want the student to first of all learn to be self-aware. So by that I mean the student should be able to actually say to themselves, this is making me feel very uncomfortable. The reason this is making me feel uncomfortable is, and to be able to actually think about what's happening right now. We also, though, want the student to learn to see both sides. Like, why is the resident being so insistent? Maybe the resident just missed an important diagnosis because he didn't do a rectal exam. Or maybe someone got very angry at this resident because he didn't do something. So why is the resident? To think about both sides to it. We also want them to think about when a conflict starts, what can you do to de-escalate it, to calm things down? So for example, sometimes it helps to take blame. It might not really be your fault, but it's better in the short term to take some blame to calm things down. We often say, at least in English, it's much better to use I terms. I feel this way. When you say you, it's very accusatory and tends to escalate a situation. Also to think about alternate solutions for conflicts. So for example, right now it's come to a situation where the resident says, do the rectal exam, the student says no. Could you maybe have a compromise where you say, I'll do it, but I'll do it later. Now, in this particular scenario, the student actually tried that. She said, could I come back later? And the resident refused, so it didn't work in this particular situation. And then also to think through the ethics of the situation as well. I mean, this patient said yes in the end, but was he being forced? Was he being coerced into doing it? When is a patient being pushed more than you think is acceptable? This is an example where we use it as a formative evaluation. It's not a summative evaluation. So the goal is to learn these things and not to evaluate the student. So in our experience, about 75% of our students refuse to do the rectal exam, like this girl did. They say no. That even if it's bad for their evaluation, even if there might be conflict with the resident, they feel it's more important not to do it. And these are the reasons they give. They say the patient didn't really consent, he was forced into it. Respecting the patient's choice is more important than following the resident's orders or my own evaluation. About 25% of our students go to do the rectal exam in this scenario, and when you ask them why do they do it, they'll say, well, I'm only a student, I don't know everything about medicine, and if a resident tells me that this is important for the patient's well-being, I should follow the resident's orders. And the patient did, in the end, say it was okay, so I have the patient's consent. So the important issue for us, at least at McGill in this, is not so much did you do it or did you not do it, but why? Why do you do it? Why do you not do it? What's the right thing? Think about it. We asked for feedback from our students, and I just want to show you some comments because I think it's helpful. So I think the situations were realistic. So they say, I've seen things like this before. It was great to have feedback. We also do it in groups of 3. So there's 3 different scenarios. 2 watch. One's the student in the scenario, then they switch, 2 others watch, one's in the scenario. Here's an honest patient. The session gave me confidence and options for future events, but what I will actually do remains a mystery. I think it's a little bit easier in a scenario like this where you will never have to see the resident again to say no than if you have to go back and see the resident the next day and the next day and so on. I don't know if I learned how to better deal with these. There are more politics in real life. I think that's also very true. And then I realized that there are no good or bad answers. Sometimes you simply have to be at peace with your decision. So I think those things show a great deal of insight on the part of a number of students. Now, I did say that we can predict somewhat unprofessionalism, and we can predict it by showing if students are irresponsible or have poor response to feedback, that they're more likely to have problems later on. But we don't actually know if we can fix it. So once you've identified these students, do they get better if you give them scenarios like this? Or is it hopeless and you should really just dismiss them now because there's nothing you can do? We don't know the answer to that. We do know that knowing the right thing to do is different from choosing the morally right thing. And it's very different from other skills, because if you learn how to do a appendectomy, for example, once you know how to do it, you'll just do it. Learning it and continuing to do it are almost the same thing. But moral behavior is different. You can be a brilliant ethicist and write a long essay and understand ethics very well, but it's different from choosing to do the morally right thing. But we also know that evaluation drives learning. So I think that what we can do with our medical education system is we can set expectations that may lead to behavior change. And so what we've been trying to do at McGill is through our evaluations of the students and of the faculty to say, these are our expectations, these are what we're looking for, and we hope that that will lead to some behavior change. Here's my own small thoughts about some of the challenges in Japanese medical education. So first of all, you need rotations, clinical rotations that are long enough to allow for meaningful clinical evaluations. So many rotations are only 2 weeks. That's very short to really know whether a student is having problems. I also believe that in most clerkships there's no tradition of narrative clinical evaluation, so people aren't writing comments. They're just checking off whether they passed the exam or not. So there needs to be, I believe, a culture of narrative clinical evaluation, or at the very least a system for making the expectations very clear, So for example, right now, for us, it's just a check mark. You don't necessarily have to write anything. You can just check off that the student didn't listen to a patient or that they were late and on time. And of course, there needs to be a culture of accountability once physicians are in practice. So disciplinary decisions have to be publicly available, which I believe they are. But you know, if you want to, at least you can just go on Google and enter Disciplinary Action State Board of California, and you will see the names of the physicians and the things they've done that have been disciplined. So that culture of accountability is important as well. So, to conclude, I decided that it wasn't so important to worry about the origins of professionalism, because there's generally widespread agreement on most of the attributes of professionalism. We do know that irresponsibility and resistance to feedback during medical school predict unprofessional behavior in physicians in North America. We don't have that data for anywhere else. It may well be true, but the data is only for North America. There's many ways of teaching professionalism, but there have been no studies that look at the effectiveness of education or remediation in preventing or remediating unprofessional behaviors. So we have this extensive curriculum on physicianship at McGill, but we don't actually know if our students are more professional because of the curriculum or not, and we really need to do such studies. So at KO, you can do that study and
I hope so.
yeah, be a leader in the field. We really need those kinds of studies. But I think that as a minimum, medical schools should at least be measuring irresponsibility and resistance to feedback, because those are the two things we know that predict later disciplinary action. And then they need to think about what you do with a student with such problem, because I don't have a scientific answer on whether or not you can teach them or not. But you do have to think about what you're going to do. You know that those students are high risk, for sure. And I think that evaluating professionalism in students and teachers has the potential to drive culture change in an institution. And one interesting thing I want to tell you for our students at McGill, at the end of 4 years, they do a graduation survey. They're asked to comment on all their education. What did they get too much of? What did they get not enough of? What did they like? What did they didn't like? Our students say they have too much teaching on professionalism. They are tired of hearing about professionalism. All the time people are talking about professionalism. I tend to agree with them. I think we should stop talking about it so much, but if we evaluate it properly, then the learning will follow the evaluation system. And that's the end of my talk for here. I'd be happy to have comments or questions in Nihongo demo, Eigo demo, dozo.
So